No man ever steps in the same river twice, for it's not the same river, and he is not the same man. Heraclitus. A sudden profit-driven decision to close an emergency facility can have a destabilizing effect on an entire region, and people deserve a complete picture on the ramifications of a potential closure. Pennsylvania State Senator Carolyn Committa. Hi, I'm Frank Spidell, and welcome to The Doctor Is In. I'm a retired emergency physician and recovering hospital administrator. In this show, with the help of guests, we explore healthcare in the U.S. and its interface with society. Now, I invite your robust skepticism of my comments. I'm human. I make mistakes. And I recommend you seek guidance from your primary physician, state and local health agencies, and the CDC for your healthcare decisions. After I finished my residency in 1980, I began practicing emergency medicine at Chester County Hospital. At that time in Chester County, there were 5 independent acute care hospitals: Chester County, Paoli, Phoenixville, Coatesville, and Southern Chester County Medical Center. In the mid-80s, the Coatesville Hospital moved to a newly built hospital in Cowan Township, changed its name to Brandywine, and was designated by the Pennsylvania Trauma Foundation as a Level 2 trauma center with surgical teams in-house 24/7. That is quality care. Times change. By 2020, Chester County had become part of medicine, Paoli part of Mainline Health, and Southern Chester County Medical Center, Phoenixville, and Brandywine had been bought by Tower Health. By 2022, Tower Health closed Brandywine. It was losing money. Then Southern Chester County Medical Center was also closed. Eventually, it was bought by the Christiana Care to be opened as an emergency care center. Now residents of large parts of Chester County face longer travel times for care, and demands for action reasonably erupted. Responses were both remarkable and predictable. Senator Muth introduced legislation requiring state approval for purchase of a hospital or a hospital system. State Representative Dan Williams and State Senator Carolyn Committa proposed legislation to increase the notification to the Pennsylvania Health Department from 90 to 180 days if sale or closure was thought. Some problem is not enough for, it's a question of regulation and control. No, I think it's not that. It's not a shortage of mandates and laws. I appreciate the value of Senator Muth, Representative Williams, and Senator Committa's interest in the involvement, but I think the problem differs from their perceptions. Senator Committa got it right, but she phrased it wrong. The closures are loss-driven, not profit-driven. So why did Brandywine and Southern Chester County Medical Center close? I suspect they cost more to operate than the revenue they generated. An acute care facility's ability to continue operations is multifactorial. Drivers are market presence, that's the size, service lines offer, and payer mix. And guess what? Medicaid and Medicare do not cover the cost of the services provided. Acute care facilities must rely on revenue from private insurance to cover the shortfalls for the undercompensated care from the feds and state payments. I suspect the payer mix in Brandywine and Southern Chester County area is significantly shifted to self-pay in the uninsured. That's called Medicaid. And I think the ongoing operation is not sustainable without significant government support. Sadly, the communities these facilities served are harmed, remain compromised by their closures. When something bad happens, people want to do something. The just do something response is completely understandable, but many times a disservice, giving the veneer of addressing the problem, but adding to confusion and frustration. Our response is best when we clearly understand the issues and the drivers of the problem. Consider Delaware County Memorial Hospital. The acute care facility was scheduled to be converted to an inpatient psych facility. A judge ordered it to be kept open as an acute care facility. Then the Pennsylvania Department of Health orders Delaware County Memorial Hospital to cease inpatient care and close its emergency department because of reported inadequate staffing. To help us understand the drivers of the contracture of healthcare in Chester County and across the country, I am honored to have Professor Harry Holt of Westchester University's Department of Health, College of Health Sciences. Professor Holt is the author of a very fine, actually outstanding textbook, Fundamentals of U.S. Healthcare, Principles and Perspectives. Professor Holt, welcome to The Doctor Is In. What did I get wrong? What did I miss?
Dr. Spidell, thank you for having me here.
I'm honored.
Everything you said sounds absolutely right. Your discussion there about the drivers of financial viability and profitability of a hospital, I think, was spot on. With regards to the payer mix, and one of the things you mentioned there with regards to the communities that are impacted by this, typically the ones that are hit the hardest are seniors, underrepresented minorities, communities that are disproportionately impacted are the poor, Black and brown Latino individuals, those that don't have transportation. And for instance, as well, the Coatesville VA Medical Center relied upon Brandywine Hospital to provide acute care to veterans as another group of stakeholders that are impacted. And you're talking about drivers, and essentially, we're talking about not having enough money. Not having enough money based upon the payer mix and the fact that the Medicaid and the Medicare reimbursement doesn't even cover the costs of care. Also talking about declining inpatient volumes, reimbursement challenges, and there's just an increased demand for outpatient care and care that's reimbursed by private payers.
Professor, you have an incredible background. Tell us how you got involved in healthcare, your Cleveland Clinic experience and your Doctor of Laws degree.
Yeah, well, I really was motivated since high school. I come from like a family of nurses. My mother was a nurse and a nursing professor. My sister, I have cousins. So there's not a lot of nurses involved with spurring me toward healthcare. So I went to a law school that really was ranked quite highly in healthcare law. And I really was fundamentally interested in how a healthcare administrator can make the difference in the life of a patient and their family, to make a difference and have that patient walk out of the hospital healthy and happy and leading a productive life. And I was thinking, what skills can I bring to the table to make that happen? And between the two degrees and the Cleveland Clinic experience, and I think I made a contribution in that.
And you're continuing to make a contribution. Right now, you're a professor at a great university, Westchester University, and you are generating more people into healthcare. And don't ever doubt you make a difference. Getting people to ask the right questions is the win. How much do we spend on healthcare in the U.S.? Is this increasing or decreasing? And let me throw out a comment. One of the things that we talk about the cost of the services we provide for Medicaid and Medicare isn't matched. When people say, oh my Lord, have you seen the prices, Frank? Well, the price is not the cost. The price is what people see. Mm-hmm. What is the price of a basket of potatoes? What is the cost to grow that basket of potatoes? So we know that, tell us about the healthcare spending in the U.S. What's happening with it?
Well, The last data that I've seen, and it's probably been impacted by the pandemic and certain other factors, but, we're talking upwards of 3-point-odd change trillion dollars in terms of healthcare spending, which translates into a per capita, of per person per year of greater than any other economically developed country in the world. So we're spending quite a bit. We're based upon, of course, the Western model of medicine, of intervention. Once a person's sick, we jump in and intervene and perform tests and procedures and try to provide all sorts of acute care, which is the best in the world, but it also is very expensive. And as opposed to, say, managing health and focusing on the social determinants of healthcare and trying to keep people healthy from the cradle on and forward by focusing on factors that actually keep them healthy, as opposed to jumping in and intervening once they're in the hospital.
You're referring to things like the adequacy of our immunization statistics, which has always been a challenge. And the other thing is some lifestyle challenges that I'm the last one to talk about this. We are an obese nation. That is definitely a driver of our healthcare. It's hard to find somebody as chubby as I am in France. Probably, but it's a lifestyle change that would help us tremendously. And that $3 trillion number, that's almost 1/5 of our gross domestic product. Mm-hmm. So it's a huge chunk we spend. Hospital closures, good thing or a bad thing?
Well, like anything, you would say it depends, right? So there's pros and cons. From, say, Towers Health and their shareholders and their executives to close something that is losing millions per month, you would say that's a good thing, from a shareholder value, from a for-profit perspective.
Now, is Tower Health a for-profit or is it not-for-profit?
Now, Tower Health, Tower Health, that's a great question. These two hospitals were going to be purchased by a for-profit equity firm, and that did not happen. But I'm thinking more on the lines of, say, a Tenet healthcare system or a Columbia and their hospital chains. So from a shareholder perspective, to stop a loss, stop a leaking ship, a sinking ship, that's a good thing. But from the perspective of communities that are underserved and lack transportation and, these hospitals that, safety net hospitals are their source of primary care, for better or for worse. And as well as if that hospital is the primary employer in that community, that can be a devastating impact upon the hospital. If you take a standalone community health center, a community hospital, whether it's part of a chain or not, and if it's a primary employer, that can be a fundamental change factor for many other industries in that region, because that's a ripple effect through the community, because new employers, when they come, they're looking for the fact that their employees have quality health care. Folks are moving in, they're looking at the school district, they're looking at the hospital, looking at all these different factors. And so it has a multiplier effect across the community when that facility closes.
When a community is looking to grow its talent base, and you want to recruit and bring people in, somebody said one time, bringing somebody in, they look at a couple things, meds and eds. What is the medical care and what is the education my family will see around here? And that's a driving force for recruitment, and I appreciate that. Do municipalities ever own and operate hospitals? Did we ever own hospitals at one time if we were a municipality?
We did. In fact, we owned like psychiatric hospitals. We owned trauma centers and safety net hospitals that, for instance, in Cleveland, you have Metro Health that at one point was owned by Cuyahoga County. And so you do have county-owned hospitals that, these are larger counties, they're not small, townships, they're not owning hospitals, but the large municipalities and cities, they definitely, in terms of psychiatric care, and of course, the Veterans Administration owns the clinics. Department of Defense has their healthcare system. So there is public ownership as well as municipality ownership of hospitals across time.
I grew up in a time when Philadelphia owned Philadelphia General Hospital, which was a great institution, which was a safety net for those with no resources. It was also a great educational institution. There was a kind of wonderful glory that a certain kind of care provider gets when they say, I'll take all comers. I don't care whether you can pay or not. I'm here for you. And that was a great time. But Philadelphia got rid of it, as did New York City have a network of hospitals for those who were marginalized where they could go. I think that the New York the New York City spun off those New York municipal hospitals into a separate entity.
Okay.
And I think that entity is having the same problem. It costs money to provide care. So that's one of the challenges I think we as a society are struggling to get our hands around it. What do you think are the biggest drivers for hospital loss? Let's say I'm Brandywine Hospital or I'm Southern Chester County. What do you think the big drivers for that loss was?
Well, at the top, you were talking about the payer mix. So there's several factors here. The payer mix is definitely a driver. If your patient population is, for whatever reason, unable to pay, and once that care is provided, maybe they have a high deductible healthcare plan that they thought that that could cover them, and that they didn't know the fine print of the fact that they have to cover the first $5,000 or the first $100 or first $1,000, or even thinking about the individual copay. It's a rare American out there that has $1,000 set aside for healthcare.
Yes.
They might have it for the hot water heater or the car, but rarely do people save up in an account on their own, for healthcare. So there's the Medicaid, Medicare drivers, barely covering costs. There's also wages and salaries that are cost drivers in a hospital. If, for instance, the hospital has had to take on more contract nurses because of the nursing population leaving due to the pandemic, or these problems existed before the pandemic, but the higher the salaries that need to be allocated toward nursing staff, that's going to chip into any profits and revenue that the hospital has. So that's a growing phenomenon where there's so many nurses that have left, but the ones that stayed realize that they can actually earn a lot more through contracts. So the wages and salaries, the payer mix, just inflation hits hospitals as well in terms of supplies and so forth. So there's and then their bargaining power, vis-a-vis the payers.
Exactly. Exactly. If they don't have, like you say, if they're a standalone community hospital and they're like bargaining with Independence, Highmark, Blue Cross Blue Shield, whoever it might be, and they are a price taker. They are a price taker at that point, which may be driving so many of the standalones to join systems so that they can come together then as a system and bargain with the payers and generate higher reimbursement. It is certainly true of physician practices. I think one of the events we've seen in my lifetime has been the disappearance of the 1 or 2 person practice, where everyone is going to the larger group practice, because you have the ability to go to the marketplace when you're negotiating for your reimbursement. When you have a large group, it's either when it's Frank and Tom trying to get the compensation. And the growth of very large mega healthcare providers, and we've seen that in our community. And I hate to say this, these institutions are great institutions. I'm a big champion of them. They offer goods and services that were unimaginable 40, 50 years ago. But unfortunately, one of the effects is in the marketplace, they sort of crush that small hospital that doesn't have quite the same level of services offered, and it doesn't quite have the same image as the large successful organizations. I was always concerned that in some ways with Medicare, and I think, correct me if I'm wrong, Professor, I think much private insurance sort of pegs and follows Medicare. That Medicare sort of picks winners and losers as by their compensation. Medicare has each year they have a given basket of dollars, and they decide how much we're going to pay for things. Dramatic interventions can get paid and compensated very well. When I was growing up in medicine, it was a little different. The market basket of goods has changed profoundly. If somebody came in with a heart attack, I've told the story time till it's threadbare. Someone comes in with a heart attack in 1980. Myself and a great cardiologist could do nothing for him. We watched this poor man in his 40s pass away with a big aneuryseptal infarct. And all we had was something for pain, oxygen, and dysrhythmics that were probably inappropriate. In 2012, at the hospital I was CEO with, we had a wonderful set of interventional cardiac cath suites. Exact same thing. A guy comes in, same time of the day, 5 o'clock at night, big aneuryseptal MI, and he's in his 40s. He goes to the cath lab. He gets 3 stents. Everything gets opened up. His heart goes back to normal. The next day at 11 o'clock, I see him. He's eating breakfast saying, "When can I get out of here?" Difference in care, different basket of goods. But Lord, the cost to have the interventional suites, to have the team standing by on call to come in, to drop everything, drop dinner and get in there. It's a change in the care we give, but it's terribly expensive. And Medicare, to its credit, has said we're going to pay for that. But at the same time, Medicare doesn't have the money for that family practitioner that's seeing seeing 4 patients an hour, 5 patients an hour, trying to get them to change their lifestyle, which goes to what you said about prevention, lifestyle changes, et cetera, et cetera. Do you think quality in healthcare, do you think that depends on volumes of patients seen?
So there's a couple ways to think about that. So the literature and Leapfrog and so forth, have looked at different types of procedures and so forth, where volume really does matter. Okay, you're talking about the gentleman that came in for the stents. You want someone working on your heart that's seeing the absolute worst possible case every day, every day. So volumes absolutely do matter in these types of situations, where the more you do, the worse you've seen in terms of whatever the care might be. But you want the evidence proves that the more that you see, you have economies of scale, essentially, and quality does matter for those types of cases.
It's not just for the operator at the end of the wire. It's for his team. It's for the people that see the patient initially in the ED. When you're used to the drill, way back when Brandywine was a trauma center, I was the ED director there, and the volumes of trauma we got, it actually helps. The more times you have to drop a central line, the more times you have to do an intubation in someone who's had facial trauma, your skill set develops. I guess if a hospital is not seeing big volumes, they have a problem with their quality then, won't they? They'll be spring-loaded to have not such good numbers.
Well, you can make that argument. It's surprising. And I'll take you back to some of the critical access hospitals out there. in Pennsylvania.
For the audience, what's a critical access hospital?
Yeah, so a critical access hospital has to be so far away from any other sole provider. Maybe it's 35 miles or 50 miles. It has less than 50 beds. It has to have a certain high percentage of Medicare and Medicaid patients. Essentially, it's a small, standalone facility that is really just to stabilize people there in that rural community, particularly. But they can have some really good quality. Some of the literature out there says, people bypass those hospitals to go to, a Geisinger or Penn State Health or, a regional medical center. But they actually, in some, for many types of stabilization, maybe it's a heart catheterization, from door to cath, they actually might be pretty good. So there's, and just to stabilize the person and then get them on a helicopter or an ambulance, if it's a trauma type of a case, the shortness of breath, a heart attack, whatever, and get them to a facility. So there's that scenario where, studies have shown that those critical access hospitals are doing pretty well in what they specialize in and what they do well. But to your point, those types of acute tertiary care, trauma 1, trauma 2 level care, intervention, cardiothoracic surgery, transplant, hernia repair, even stent, aneurysms. You want labor and delivery. You want to have high volumes.
Yes.
And the Leapfrog group has done a great job in measuring those and looking at how that volume impacts the quality of clinical outcomes in a hospital.
Yeah, I'm in complete agreement with that. It's one of the challenges that a small volume acute care facility has to try to manage. Going forward, what can we do to improve access in the county?
In the county? Well, I think, fundamentally, big picture, your comments at the very top, I think, were very prescient. And that is, we have to look at healthcare and determine, is it going to be something that's a common good that society says everybody deserves world-class care, regardless of what you look like, your ability to pay, where you're located, and are we willing to invest in it to the extent that we have determined other things are, a common good, like, education, and which is very different. I totally understand that, but education and Head Start and all the other things that society has determined, everybody deserves an equal funding, equal chance. So we get to that issue, by looking at funding. Maybe it's expanding the eligibility for Medicare in terms of ages. Maybe it's subsidizing more our products that we offer on the state exchanges through Obamacare and the Affordable Care Act. Funding for these hospitals, from at the state level, expanding Medicaid even more through the Affordable Care Act. So that a lot of that's driven by this paradigm, this worldview of, do we believe that healthcare for everybody is in society's best interest to fund and to invest in as a common good? And then that trickles down to, where we fund it, how much we fund it, what we fund, and to make sure that everyone deserves care and shouldn't be worried about going into bankruptcy when they get their bill.
I completely understand what you're saying, Professor. And this is the perspective I hope that you would bring to share with our audience. I cannot thank you enough for being our guest today on my guest today on The Doctor Is In. I'm starting to sound like the papal we. And to you out there, thank you for watching The Doctor Is In, and be safe.